Okay, so this is our topic, how, we've got tough decisions in the healthcare sector. I'm sure many of you experience this directly, and I'm going to talk about using multi-criteria decision making, and I'll explain what that is in just a moment, to assist with some of those decisions. So my plan for today is really an overview, particularly for people who haven't come across MCDM and the associated software before, but also for people who are more familiar with it. And I really want to focus on four, I think, very important examples you can see on the screen in front of you, and they're healthcare decision-making applications, of course, all with the focus on some sort of prioritization. And of course, the need for prioritization, no matter which country you're in or health system you operate under, is of course driven by a scarcity constraint, having to make tough decisions because there are either, there's not enough resources to fund all patients in my first example. So I'm going to talk very extensively about using MCDM, which I am going to explain in just a moment what that is, to make these decisions. And so we've had a lot of experience in New Zealand, certainly. In fact, since 1998, the New Zealand health system has made just about all of its decisions for the allocation of elective services to patients using MCDM, and in particular using 1000 Mind software, which of course I helped co-found with Franz Ombler as well. And so I'll talk about that. I'll use that actually as my major example to motivate what MCDM is with that example. But the other three applications that I'd like to talk about in sequence, and I'll use the second one to demonstrate an application of 1000 Mind software as a software for doing MCDM, is, how do you decide which health technologies, as they're often called, in other words, drugs and devices and procedures and equipment, all the things that you could buy in a health system, either at the national level or perhaps as a health insurer, depending on the country. And in particular, how do you allocate a budget? You've got a limited resource, so how do you get the best value for money across all those different things that you could spend that money on? My third and fourth examples I'll spend less time on, and they're in some respects more recent, but a project that we were involved with the World Health Organization to rank order and therefore prioritize diseases that are becoming antibiotic resistant, and to put them in a ranked order to try and recommend to researchers the sort of priorities for doing research to find new treatments for these diseases that are threatening to come back with a vengeance. And the fourth one, 1000 Minds and our colleagues here in New Zealand, as the COVID crisis enveloped our country, we set about, at a very rapid rate, creating a system and a tool to prioritise patients for admission to intensive care in the event that intensive care was overwhelmed. Now, fortunately in New Zealand that didn't happen, but of course in other countries it did. So that's another example that I want to talk about. So I'll use all of these to try and illustrate what multi-criteria decision-making is. As I said, my intention is after sort of each of these four topics, I'll have a little pause and maybe we can throw it open and people can raise questions or comments, but of course use the chat or the Q&A in Zoom as well in order to do this, to have this sort of back and forth in conversation. Okay, so what is multi-criteria decision-making, or MCDM as it's often called? Well, another name for it, it's sometimes referred to as multi-criteria decision analysis. Those terms are pretty much interchangeable. As the name implies, it's about decision-making when you've got multiple criteria to consider. And if you think about it, that covers so many areas of our lives, professionally and personally. It's a very broad and generic area of decision-making, and a sort of a more focused description, as you can see on my slide. We're trying to prioritize things, or we're trying to rank things, or we're going to make choices, and of course from amongst different alternatives, and those alternatives could be, as I said before, they could be treatments, they could be courses of action, they could be diseases that we want to research, or of course they could be patients, individuals, people themselves. And we're going to make those choices by considering multiple criteria that we use to choose between them, or objectives that we're trying to achieve. It's a discipline in its own right, and it lies sort of at the intersection, as my clumsy Venn diagram is trying to illustrate, of those three noble disciplines. Of course, I'm an economist, but one of my great joys in the last 20 or so years has been mixing and matching, if you like, with psychologists and certainly computer scientists and operations researchers. So it's a large and I would say increasing area that sort of lies at the intersection of those three areas. I'm going to give you an example as to how this stuff works in just a moment, but just some sort of high-level motivations. It is widely used, and I'll give you lots of examples more broadly than just health. Well, why is it so broadly used? And in essence, I think these pictures illustrate it. Economists oftentimes and some other social scientists like to think of human beings as being very rational and properly informed, and therefore super smart and very capable of making decisions, sort of as illustrated by the two individuals on the left. But in reality, probably more of us are more like the individual on the right, more like Homer Simpson. We're driven by emotions. We're driven by, it looks like a donut distracting Homer. And so we often don't have the right facts in front of us, and we're influenced by our cognitive biases. We sometimes have emotions at play, and these are all wonderful things that we celebrate as humans, but oftentimes they lead to the wrong inferences and therefore oftentimes the wrong decisions being made, ones that we might look back and regret. So certainly we celebrate being humans. I can't think of anything more exciting than being a human being, but we recognize that at times we don't necessarily make the best decisions. So MCDM is a set of tools and techniques to try and improve our decision-making as individuals, but also as organizations. The psychologists, the organizational theorists study these things, and here's what I like to bring up at this stage, a very nice sort of summary of the types of mistakes or common errors that we all make as individuals, and certainly you've probably seen them in organizations that you're familiar with. I won't go through them all. One I like to focus on myself, I work at a university. I'm often astounded by what's referred to as group failure. I'll attend a meeting with some of the smartest, most well-educated people that I've ever encountered. We'll make decisions, at a management level sometimes, and oftentimes I'll come out the other side going, how on earth did such smart people arrive at such a strange decision? And so that's an example of group failure. But you can probably think of in your own lives, in your own professional lives as well, any number of examples of this list here. And of course, our intention with multi-criteria decision making is to try and reduce and minimize the frequency of these errors so that we make better decisions overall. I want to give a plug for this wonderful book that in some respects changed my life. It's an excellent read by Daniel Kahneman, the Nobel Prize winner in 2002 in economic science. He's a cognitive psychologist. Those three chapters that I've identified there are really the foundational references or explanations as to why human beings struggle with tough decisions. And Kahneman is a very strong advocate for using what he refers to as formulas, which is really just his way of saying multi-criteria decision making, to support our intuitions and oftentimes to replace and certainly improve upon. So those three chapters discuss sort of the psychological basis of that and review the literature, looking at the success of, as I say, what he refers to as formulas, but what we would more commonly refer to as multi-criteria decision making. And of course, it's beautifully written, and the whole book is actually a joy. So if you haven't come across that, you should really keep your eye out for it. But as I say, it's a good background to in terms of the psychology of this area overall. So what are some examples? Well, there's thousands and thousands of examples of multi-criteria decision making, and I've just repeated the definition there so that particularly for those of us who are new to it, we can keep remembering it. Again, it's about prioritization, it's about ranking, putting things in order, it's about making choices when we've got multiple alternatives or individuals, and we're going to use criteria. So these are examples. On the top left, of course, are there's the four that I'm going to talk about in my talk today. Another three below it that are very much part of what 1,000 Minds does as well, but and other people, of course, which I'm not going to talk about in this talk, but I could certainly share other information if people wanted to. I'm not talking about the other three in this talk because they're not so focused on actual prioritization or decision making subject to scarcity. But all these other areas, of course, outside of health are applications that we've worked into, of course other people do as well, covering broad range of different areas, but common to them all is ranking or prioritizing based on considering multiple criteria. and so on and so forth. We could go on endlessly. So private sector applications, government sector applications, educational applications, personal applications again. All of those applications, as broad and diverse as they are, have four things in common. And this is going to be a common theme of my talk. I'm going to keep coming back to these four things which I've bolded in my list on the left. So there are really four things that make up a multi-criteria decision-making setting, and therefore four things that we should try and get as right as we can when we're making decisions, be it in health or any sector. So I'll keep coming back to this theme. It's a sort of a mantra, something to go through if we're trying to make a good decision. And I'm going to use the example here, you can see it on the right-hand side, of prioritizing patients for an operation for heart surgery, which is known as coronary artery bypass graft surgery, or CABG, it's often referred to by the medical people. This is an example that I'm going to use, and the example on the right-hand side is an example of what's known as a point system or a weighted sum model, which I'll address in a moment. This is but one of many examples that we've been involved with since 2004, creating in the New Zealand health system. So there's the CABG example that I'll talk about, but there's many, many more, pretty much over 20 such tools or systems have been created with our support in New Zealand since 2004. And a big part of the New Zealand health system at the elective services level is the prioritisation of patients in the public health system for different specialities, of course, using multi-criteria decision-making using these systems. Now I'm focusing on the one on the right because that's very much in the public domain, and I'll come to the reference for that later on, just so if anyone can follow up if you want to read a paper that uses this example. Okay, so four things to get right. We've got to think about, well, what are the alternatives or the individuals that we're trying to prioritize or rank? So here's another very simple illustration. So imagine in this case about a dozen patients. Now, of course, at a health system level, it wouldn't be 12, it might be 12,000, but of course, very, very scalable. So we're going to try and rank and put these patients in order for this particular form of heart surgery. And we're going to do it, make those decisions by considering some criteria. And on the right-hand side is a list of clearly very medical criteria. There's 8 of them. So recent acute coronary syndrome, ACS, during last 2 weeks. Who knows what that is if you're not a medical person, but it's an important consideration when determining the extent to which a patient needs this particular heart surgery. So each of these bolded headings on the right-hand side in my system is a criterion, and you can see each of those criteria have a number of levels in terms of either the severity of the condition or something that indicates how important or how beneficial the treatment would be for this particular patient. So, and these can be medical criteria, ethical criteria, social criteria. And so there's really, if you think about it, there's an art and there's a science to doing this sort of stuff. And a lot of the art, and I'm going to address how this art gets started, comes down to working out, well, what are the criteria for the particular decision that we're working on? And I'll suggest how we support decision makers coming up with the criteria, and how would we characterize each of the criteria in terms of the levels. So again, for those of us in the seminar today who aren't particularly medically orientated, this probably will look very, very foreign, but to medical people, to heart surgeons, these criteria and these levels are measurable. Some are obviously quantitative, some are just yes, no sort of qualitative things. They can be binary, they can have a number of levels of performance, etc., etc. Okay, so even having worked out what the things are that we're trying to rank or prioritize, and we've figured out the things we want to consider doing that, so 1 and 2 on the left there, the really hard thing is oftentimes, well, what's the relative importance of these criteria for the decision? In other words, what's the weights? And weights are often also referred to as points or preference values, a number of different terms for the same thing. And on the right-hand side in my illustration, down the right is obviously a set of numbers, and those are the weights that represent the relative importance to the decision makers, my 4th point on the left, when it comes to thinking about this very, very important decision. And very easy to interpret. The best way to think about how to interpret the weights is if there was a patient who had the highest level on each of these criteria. So had, I'm not even going to try and say it, ACS, hemodynamic instability, blah, blah, blah. The coronary artery anatomy was left main stem greater than 70, class 4. So basically the highest level, or the furthest down the list on the right-hand side, we would simply add those numbers, so 26.9 plus 17.3 plus 12.4, right down to 5.1. So we'd have 8 numbers that we add up. If you add those 8 numbers, the score would be 100. And that's why beside each of the numbers is a percentage sign. So the maximum score that any patient hypothetically could get is 100 points. Of course, at the other end, the lowest level of performance in terms of rating for each of these conditions or each of these criteria, you can see the bottom thing, no ACS 1 or 2 vessel, no angina, so on and so forth. The corresponding weights for those levels are 0. The sum of all the zeros, of course, is 0. So this means each patient can be scored between 0, which would give them the lowest priority, up to 100, give them the highest priority. The reason I'm emphasizing that is because out of a maximum of 100 points, you can see the weight going on that first criterion is almost 27%. 27 of 100 points is accounted for in terms of importance by that first criterion. And these criteria here, just for presentation purposes, are ranked in order of that maximum number value on each of the criteria, right down to the least important thing down the bottom, just 5.1. Now, of course, just, and that's the beauty of having numbers. Because they're quantitative, we can say things like, for example, the first criterion, getting a weight of 26.9 out of 100, say versus the least important criterion, a weight of 5.1, that first criterion is more than 5 times more important than the least important criterion. And we can say things like that. Now, of course, the $64,000 question in all of this is, where did these numbers come from? How do we know what the weight is? And that's really what one of the biggest things that multi-criteria decision-making and software that supports it is designed to do. And I'll talk about methods for achieving these weights in a little while. Okay, so, and these numbers here are, as I say, from a published source. These are the weights, at least as far as I know until recently, that are used to prioritize patients for this operation in this country, in New Zealand. So we get the alternatives right, we think about the criteria, we figure out some weights to represent the relative importance, and then of course, last but not least, and probably should be top of my list, all of this is designed to represent the preferences or the expert knowledge of the decision makers, and depending on the application, the other stakeholders who might be relevant for this decision, perhaps the people that are affected by the decision or who are represented by the decision makers. Clearly in this example, the other stakeholders would be things like patients, but they wouldn't be probably involved in these criteria because these are clearly very medically orientated, but the clinicians who are acting as experts would be acting on behalf of the patients. Okay, so if we have a system like this, if we've arrived at criteria and we've ended up with weights on the criteria representing the relative importance, the way that we'd implement our system, and again, just a bit of terminology, this is a point system.
Sorry, Paul.
Yep.
We have a question.
Great.
So the question is the comparison, I don't know how to pronounce that, comparison of the relative weights is done automatically, or will 1,000 minds will produce it?
1,000 minds will produce that. So I'm going to show where those weights came from in just a moment. Absolutely. Yeah. So I'm sorry I didn't make that clear. The holy grail, if you like, of multi-criteria decision-making in general and all the tools to support it is really coming up with, well, what are the weights? How would we know what they are? And so there's a whole bunch of techniques that have arisen. And from the very most basic, let's just make the numbers up out of our head, to using much more sophisticated tools and techniques, 1,000 minds being an example of that. And I'm going to illustrate that in just a moment, okay? But you're absolutely right. That should really be the thing that's flashing in your mind. Where are these numbers coming from? And so that's what I'll illustrate, certainly. Okay, so if we've got a system like this, and it's a point system, and I think in my explanation, I emphasize that we were adding the numbers, so they're often known as additive point systems. Another name for it is a weighted sum model. We're summing up the weights in order when we apply this to be able to rank order the patients. There's my patients that we're trying to rank, and so we describe each patient according to their performance on the
Sorry again,
criteria. We
Paul.
rate them in essence. Yes. So
We have another question.
another question?
Yeah.
Fabulous.
Is it possible to use an outcome with different levels, for example, through or more different diagnoses?
Different diagnosis. Well, it's certainly, yeah, well, I guess this relates to this. Each patient here in my example is getting a different diagnosis. So they're being diagnosed according to their performance on those criteria. So you can see patient P through to D has a different performance on these 3 criteria that I could fit on my screen, but also on 5 other criteria. So that's a different diagnosis. And then they're being scored, right? So based on their diagnosis, in essence, based on their performance on each of these criteria and the system that I'm showing here, their implementation would occur like this. And the software, or the analyst, you don't need software, you can do this in your head or using Excel, is simply adding up to get a score out of 100. And there's the score in the 3rd column, and the patients are being ranked according to their score. They're being prioritized. So the interpretation here would be a patient P diagnosed with these characteristics on the criteria that are in the system would get a score of 91.2. Clearly, that's the highest number there on the list. They're all ranked. So patient P would get prioritized for the operation before patient F, before G, and the last patient, poor old patient D, getting the lowest score, would have the lowest score and therefore would be coming last on this list. So I hope I've answered that question. So that's how we'd implement it. Now I'm going to show how this operates in another example just in a few wee minutes, okay? Before I go on, so sometimes a common reaction against this system is that this seems very simple. You just add some numbers up, you get a score out of 100, and then you use to rank patients. I mean, this seems a bit naive and childish, and that's a common reaction, particularly from experts who have spent years training and perhaps thinking about these problems. In fact, there's been a huge body of research over the last probably 50 or 60 years looking at the validity and reliability of that approach, and the overall conclusion, which I've summarized from these experts here, and again, this is another excellent book, is that these systems work extraordinarily well, surprisingly well. They outperform the expert judgment of experts themselves not using systems like this, which seems like a very, very undermining or challenging claim, but that's certainly the evidence across a huge range of areas of application, not just health, but just about every application that you can think of. It performs very well. I won't read out these quotes, you can look at it, but basically a very strong plug, and oftentimes a very dramatic pushback against this notion. Some other conclusions there as well. Again, I've given you the sources if anyone wants to follow that up, and certainly I'd love to talk to people afterwards about this stuff. Now, I think these were the kind of the questions that some people were thinking, and I want to address that directly. It's, begs the question, well, in the first place, how do you know what the criteria are and the levels are for this decision that you're trying to work on? And secondly, probably even more challenging, how do we know what the weights are on the criteria and the levels? So in other words, just to make it really, really crystal clear, how do I know what these criteria are for this form of heart surgery, and how would we come up with those? And not me, by the way, but the actual decision makers, the clinical experts. And moreover, how do we get these numbers that we're going to then implement in our system? So I want to try and address those two questions one at a time. So the way a lot of people do it, the way we do it, certainly in 1,000 Minds, is we have the experts create sort of patient case studies. They're often called vignettes. And a vignette is a description of either a real or an imaginary patient. The description has all the sort of relevant information that the decision makers would use when they're thinking about the decision that we're considering. So here's a screen from 1,000 Minds, and this is not for cabbage surgery. This is for another type of treatment. I didn't have a cabbage surgery example, but so here's, for example, a patient, a 12-year-old, usually healthy boy with a whole bunch of medical characteristics. This is from an ICU example, actually. Here's another description of a patient. Again, these are written in terms for experts in the area who know what all of these things are. So a starting point in order to arrive at, what are the criteria that we would use for rank ordering patients for this operation, is to give a whole lot of examples of possible patients to the experts that we're engaging in the process, and have them first as an exercise, partly to get their attention, but in particular to try and get them to think about, well, what are the criteria and the levels that we would use when we differentiate between these patients, when we think about the order that they should be treated in. Give them what we call a ranking survey, get them to try and put the patients in order by looking at the information that's available to them. And the information could be much more extensive. It could have photographs, it could have links to other sources of information relevant to that patient, the same sort of information that they'd use in a clinical setting. Get the clinicians to do this on their own, to put them in the order that they think they should be treated. And following a discussion of the results, I'm going to show you some results in just a moment, have them as experts with facilitation discuss, well, what are the things that we think are really important for how we made these decisions ourselves, and try and reach some sort of consensus. And this can take weeks and months. And of course, with reference to the literature, there'll be a literature out there. The experts have had a lot of experience doing this. They've been trained in this, but really we're trying to capture what they think is important. There may even be existing guidelines. The cabbage example that I've been talking about so far, there were guidelines before the creation of the system that I showed you that they were trying to extend upon. So there's oftentimes a good starting point, but this is a very good way to get the experts really thinking about, well, what are the things that we care about that we think are important when we make these sorts of decisions in our daily practice? Because remember, what we're trying to do here is codify what experts would do. The other great purpose of having them do the survey is you can illustrate to the experts in a very dramatic fashion, and this example here does just that, how variable their clinical judgments are. So this is a real life result from a survey, a ranking survey like that, going back to cabbage surgery again. So let me just explain the graph and you'll get the point immediately. So there were 10 experts in the groups, and so there were heart surgeons, cardiac surgeons, etc., like some of the best in Australasia, chosen for that purpose because their expertise was considered valuable. So there were 10 of them, and they're represented in the graph by these little shapes and colors here. And they were given the task, they were given a list of 12 patient descriptions, vignettes, patient A through to L, and they're represented in the graph along the horizontal there. And they were asked individually, working on your own, read all the information for those 12 patients, expert, and please rank them in order that you think they should receive heart surgery. And do that on your own, and then we'll look at the results and try and see the similarities and differences. And as I say, use that as a springboard to start discussing, well, what are the things that we think matter when making this decision? Now, this graph shows the results, so very easy to interpret. Patient E, for example, that was a particular patient description. 9 out of the 10 clinicians agreed that that patient should be number 1 on the list. So they should get treated first of the 12 patients. Everyone agreed based on the information that this person was most urgent or likely to benefit, with one exception. One person put them as number 3. So very strong agreement there. I'll go to the other end. Patient F, most of the clinicians, not all of them, but agreed that that patient should be towards the end of the list. So either 12, 11, 10, one person, a couple of people put them as 8. Strong agreement, pretty much. But look at patient L, for example. The same patient, when looked at by 10 different experts with enormous expertise and training, huge variation. One of the experts said that that patient should be number 1 on the list. They should be treated before all the other patients. At the other extreme, one of the experts said this patient should be treated the second last on the list, and everywhere in between. Huge variation. This gets the experts' attention. And this isn't meant as a criticism, it's just demonstrating very effectively, the general result that human beings they look for different things, and we have different preferences and different things that we think are important when we make a decision. And that's one of the driving forces behind trying to come up with a system that's consistent, that everyone can agree upon. Go through the whole process. I'm going to give you more illustrations. There's the reference I talked about before. Come up with some criteria. This could take months. Come up with some weights. I'm going to show you how that happens in a moment. And then we can have a system that everyone agrees with. And then perhaps say 4 months later, we can compare, and this crude graph is doing just that, we can compare the ranking produced by the tool, in other words, the criteria and weights, apply the criteria and weights to those same patient descriptions just as a test of validity. And that's what the red line there is producing. So there's the rankings from 1 up to 12. There's the patients along the bottom. The red line is showing what the tool would produce, the prioritization tool, and compare that with a ranking of the same patients based on a consensus, really just the average results, but with some discussion. That black line there, get all the clinicians to agree working as a group after they've done it individually. And then that enables us to look at the correlation, see how close things are. And you can see very strong correlation, and at which point the clinicians are going to go, well, this system that we've created captures what we think on average as an expert group. And so that gives them great confidence. And of course, there's other tests as well. How are the weights determined? Well, huge industry doing that. One way to do it is just off the top of your head, start making them up. And that's what, in essence, people do if they don't have methods that we've got available here. Another method is you can use statistical analysis if you've got big data sets. And of course, that's what data mining and some of the stuff in artificial intelligence is about. If you don't have the data sets, what can you do? Well, there's a huge industry from operations research and computer science coming up with different techniques and usually implemented by software to ask questions and tease out from the experts answers, which can then be translated into the weights on the right-hand side here. And so they all go by fancy little acronyms. You've got them there, and I'm going to talk about a couple. Probably the most widely known one is the Ahp process. Paprika is the one that Franz and I invented and that we have in 1,000 Minds. And of course, nowadays, most of these techniques are, of course, implemented using computer software. And here's a comparison table from Wikipedia, which is a very sort of up-to-date sort of summary of the software internationally that does that. There's 1,000 Minds that we've created and we've been doing for 20 years. Here's the other couple that I talk about in a whole bunch as well. And I just want to compare in particular the Paprika method that 1,000 Minds uses, and I'm going to demonstrate the software in just a moment, versus the Ahp process, which is also quite a, well, you can see it on the table, a very common approach that some of the other software uses. So here's what the Ahp process does, used by those other softwares. It basically asks a strength of preference question. Here's an example. So sort of on a scale from 1 to 9, although it's usually expressed qualitatively. So the user would be asked, looking at these words on the left-hand side here, how would you describe how you feel about one criterion? I'm still sticking with the surgery example. Severity of angina, that's important. So the coronary anatomy. How much more important is the first thing than the second thing? And so the respondent has to choose one of these 5 options here. And one of these 5 options in the background translates to a ratio indicating how strongly they feel about the first thing relative to the second thing. I don't know about you, but I find thinking about those things in sort of ratio terms like that, and even, is it very strongly important? Is it extremely important? And moreover, I probably wouldn't be aware of it if I was using the tool, but why does necessarily very strongly important correspond to something being 7 times more important? Why couldn't it be 20 times more important, etc.? So, there's some concerns about that, and therefore some questionable issues to do with validity and reliability and how repeatable it is. But nonetheless, this is a very common methodology. The Paprika method that Franz and I invented quite a long time ago now, and that is the basis of 1,000 Minds software. There's an acronym. If you want more information, it's easy to find on our website, and there's lots of supporting information. So I'm just going to show you what it looks like, but not go into the maths, of course. Asks simpler questions that just involve a preference ordering or an ordinal expression of preferences. And I'll illustrate this in another example in just a moment. Basically, the experts would be asked to choose between 2 hypothetical patients, the one on the left defined on 2 of the criteria at a time, versus the one on the right, defined on the same 2 criteria, but with different levels. And the levels are set up deliberately so that there's a trade-off involved. If you don't know much about heart surgery, it probably won't be obvious to you, but the clinician is being asked to confront the patient on the left has worse angina than the one on the right, but the one on the right is more severe when it comes to the other criterion. And so the expert is being asked to weigh things up, to make a trade-off and to express a preference. And they're going to be asked a whole series of questions, maybe 30, maybe 40, perhaps even more, depending how large the system is. One of the major advantages of the Paprika method is that we're just asking people to choose basically the same as you get home from tea. Would you like a glass of red wine? Would you like a glass of white wine? Or in my case, both. They're equal. And that's a thing that people are very, most of us as humans are making choices all the time. We're not used to saying, well, something's 9 times more important or 7 times more important, but we are used to making relatively simple pairwise choices. And so that's I think a major example. I'll stop talking in just a moment, and then I'm going to give a demonstration, but I just wanted to highlight the overall process, which I've sort of been touching on indirectly, but this is a nice sort of roadmap of MCDM. Has sort of a series of stages, you can see them in front of you, but with lots of feedback. So, the very hard bit oftentimes is, well, what's the problem we're trying to solve in the first place? And of course, that's a very, human-centered, facilitated process. It can take a fair amount of time. The model building side of things is where a tool like 1,000 Minds and those other tools comes in. We're going to specify alternatives, criteria, just like I talked about in my example. We're going to elicit the values or the weights from people using the various methods. That might drive us back to think about the problem again, and we're going to move forward and ultimately arrive at a decision. Just again, there's plenty of resources here, but and I hadn't touched on it other than a couple of these steps here, but of course there is a sort of very careful and flowing set of steps and processes essentially associated with that model building stage in that sort of overall process that we're talking about. I'll take a breath, and if anyone's got any questions, and then I'm going to launch into just giving you a demonstration and a different application. Has anyone got any other questions that they want to bring out or comments while I catch my breath and you give your ears a rest? Any comments or things that people want to discuss? All good? Okay, great. What I want to do now is my sort of second application, and that was the notion of, suppose you've got a limited budget. Maybe you're Pharmac in New Zealand, or NICE in the United Kingdom, or an HMO in the US, a regional health authority in Canada, and you're trying to make decisions this time to prioritize the different things you could spend that money on, the devices, the drugs, the procedures, subject to your budget constraints. So I'm going to illustrate how 1,000 Minds would support that decision. By the way, you're very welcome to grab a trial of 1,000 Minds, very easy to do. And some of the ideas I'm talking about here are also discussed and illustrated in this publication that I wrote with Ahp Process about 10 years ago. So I've gone into 1,000 Minds. This is multi-criteria decision-making, obviously. This is my account. I've set up some examples for the seminar. And I want to talk about health technology prioritization, and I'm going to allocate a budget. So I'm just going to very quickly go through a simple illustration of how software like this would be used to support this decision. So remember, the setting is we've got a fixed budget, and we want to try and allocate it across a whole bunch of possible treatments or drugs or devices, whatever it is that we're thinking about that we could spend our money on. So I won't spend time going into everything, but basically, as I said, the first issue is, well, what are the criteria by which we're going to make judgments across the different uses for these resources? So I've kept this very simple. Here are the 3 criteria that we're using, and they're deliberately generic because we've got to look across a whole range of different uses for the resources, across the whole health system. And each criterion, as you'd expect, has a number of levels of performance. And in this example here, they're very generic, not very granular. We could make them more granular by adding more levels. They can be quantitative. So qualities are a measurement of the number of life years that are saved with the treatment, adjusted for their quality. So many of you will be familiar with that, but that's a quantitative measurement. And we might have, as sort of a catch-all, there would be other social and ethical benefits that we would consider, thinking about minorities or looking after children or whatever the, depending on the country, those issues would be. Now, I like to think of those sort of criteria in this particular example as being sort of related to, well, what's the health system trying to achieve? What's the objectives of it? What are the sort of the benefits associated with these treatments at a sort of a macro level? But of course, there's going to be other considerations that are important as well. So they'll come into the final section when we make a selection. But as well as what we're calling criteria, these considerations like how much do the treatments cost, and maybe the strength of evidence, and perhaps there's strategic considerations, would be things that we want to consider as well. But we're going to keep them separate to begin with, but bring them all together at the end when we go and allocate the budget. Okay, so very quickly again, so here are the health technologies or the treatments, and of course they need to be described on the criteria, and obviously we've done this ahead of time, and that could be quite a long and involved process involving people's expertise, but they've all been rated, very easy to do, you know, according to their performance on the different criteria, and other information has been gathered, and this can be entered manually or it can be added in by Excel depending on it. And of course it's highly scalable. We've only got 14 here, but it could have, you know, 140. It's just as easy. Now the big question is, what's the weights on those three criteria that we're using? So before we get going, they're all equal to start with, and I've already explained how to interpret those. So the beginning point is all of those weights are equally important. That's going to change now when the decision makers answer these questions involving trade-offs, in other words, the paprika method. So either individually the experts would be involved, or this could be sent out as a survey. Potentially we could involve an entire population if we could express the criteria in non-technical terms. But basically here's a whole series of trade-offs, and we can watch the progress bar. So the trade-off here is the hypothetical treatment on the right will generate more health benefit, more quality adjusted life years. So you'd like that treatment, but the one on the left is stronger when it comes to thinking about those other social and ethical benefits, which I'm being very general about here, but of course you could be more specific. So it's a trade-off. Do I want to save lots of lives and improve people's lives, but you know, maybe it's not looking after distributional concerns, or am I willing to sacrifice some of that to perhaps look after minority groups? And so a whole series of decisions like this, I chose the one on the left. Now a new question made up of another combination of criteria at a time. And again, I'll go through this very quickly, but basically we're just considering a trade-off each time. And the progress bar is monitoring our speed, and we're getting faster and faster. Basically, the software is being trained by our answers to these questions. And in other forums, this would be known as a predictive algorithm. It's sort of a form of artificial intelligence, but we're transferring to the software our expertise or our preferences by the way that we answer these questions. Again, I'm not even looking at the answer, so this will have no validity. But if I were, the weights that come out the other end, and we're almost there. Now let's look at the results, and notice the weights have all changed. So the way that I was answering that was, I was putting most weight, again, I was clicking randomly, but I've been doing this seriously, most of my weight was going on that criterion, least of my weight was going on that criterion. And so that's representing my preferences. When people do this for real, this is oftentimes the aha moment. People go, that's incredible, it captured my preferences. Now, of course, we want to do something with this information, and I'm, in the interest of time, I am rushing through. So here are my 14 treatments. They're described on the criteria, like I said before. Software's added up their scores and has produced a ranking of them from number 1 down to number 14. Now, if we weren't constrained by a budget, we'd just take the number 1, the number 2, number 3. But of course, we've got to try and make a decision subject to having a budget constraint. And that's where the final stage in this illustration, we try and figure out the value for money. Again, very quickly, this graph is showing there's the score out of 100 for each of the treatments, and there's the amount of money that they're going to require to fund. And so most people, of course, would be attracted to the top left because we're getting more bang for buck. We're getting better treatments in terms of performance on the criteria without exhausting our budget. And the ones in the bottom right are obviously very expensive, and they're not performing as well in terms of our criteria relative to the other things that we could spend our money. And we can start to make allocation decisions. I won't do that in the interest of time, but this is a very dynamic tool, you know, where we can make choices and actually select things and play with things and test our sensitivity and do it in a very transparent, explicit way that can involve, you know, everyone who's involved in the decision at this stage of the application. So that in a nutshell is a very simple and straightforward illustration, I think, of how the tool works in an application like that. But of course, the same sort of things would be done for ranking patients, but we wouldn't have the budget constraint stage of things. So again, let me just pause for a moment before I move on to my third and fourth and final illustrations. Does anyone have any questions or comments that I can address in that example that would be of interest? Any questions popping up, Petra, or anyone want to just jump in with a question?
Yes, I was just, I was just reading it. So Paul
Yeah, sorry,
actually is asking, Kahneman and others argue that MCDM is better, more consistent at making good decisions than expert without such tools. Is there any academic thinking that argues against MCDM as a decision support? And if so, what's the argument?
I suppose I'm a little bit biased when I think about that. I don't think there is a strong argument, but there is oftentimes a very great pushback because, in fact, a lot of decision makers aren't interested in being as explicit and transparent. They like the sort of, not the secrecy, I'm not saying it's a conspiracy, but they like doing things without being held so accountable. It's not to say that MCDM leads to perfect decisions. The question is, does MCDM on the whole lead to better decisions? And the evidence for that, as Paul mentioned, is strongly in favor of that. But there's certainly a lot of pushback. In fact, and that Kahneman book, that chapter 21, has a great review of the opposition to MCDM from people. So actually that would be a great source to look at the pushback. But Kahneman is dismissive of those criticisms. But it's an interesting issue. Yeah, that's a great question. Thank you. I might just push on a bit because. Oh, great, fantastic.
So I see there's a trade-off between the number of levels we have in each criteria. Do you have a rule of thumb for setting the number of levels?
Yeah, that's a tough one. It's definitely a trade-off. The more levels you add, the more questions you get. The simple answer is the levels that you have should be sort of appropriate for what the problem you're trying to solve is. So let the theory or let the application sort of drive you towards thinking what are meaningful distinctions between the levels that I might want to identify. There's a nice feature in 1,000 Minds, I didn't show it, but whereby the software will what's known as interpolate, so you can have more levels than you. In fact, I've done it. Actually, I'll just close that. I just see it below. I did it. So I had, for example, 5 levels there, but the software was only asking me questions involving number 1, number 3, and number 5. So you can blow out the levels and still keep the number of questions down by using that feature. But there is still no sort of simple solution as to what's the appropriate number. It really depends on the application. Most people, in my experience, though, would probably not have more than, say, 5 or 6 levels, maybe 7 at a push, because it's usually not meaningful to have more than that. That level of granularity is just sort of adding unnecessary complexity. But it's a case of sort of trial and error, see what works, see what doesn't, see if it's answering the question that people want. Yeah, that's a great question. And by the way, I'm very happy to talk after this thing. Anytime, you know, we can anyone who wants to stay online, we can have further discussions, and certainly later on next week or this week as well. My third example, which I'm going to do.
Sorry, Paul, we have another question.
That's great.
Can 1,000 Minds generate a link to the trade-off survey that could be shared with a large group of patients?
Oh yes. So again, I'm sorry I haven't demonstrated anything. I'll happily demonstrate it later on. It can be all survey based if you want to. So in my example, I was doing it maybe as an individual or doing it as a group working together, but it can easily be sent out as a survey to potentially thousands, even tens of thousands of patients or individuals, depending on the application. So 1,000 Minds has amazing surveying tools as well. And I'm sorry, Franz, I didn't make that point, Franz being the developer of this stuff. The surveying tools are incredible. So I'd love to show that to anyone at a later stage, absolutely.
And how has 1,000 Minds managed to eliminate the inconsistency of the decision maker?
Oh, that's okay. That's a great question. That's part of the paprika algorithm. So fundamental to answering those trade-off questions is enforcing consistency. And so your reaction is, well, what if people are inconsistent? So 1,000 Minds, especially in the surveys, builds in some redundant questions to try and test if people are being consistent. And if they're not being consistent, you know, we can keep them out of the survey if they're just randomly clicking like I was in my example, or that might be a good signal to the decision makers that they haven't really thought carefully about what their criteria are, and they're not sure of thinking about the problem, and they might want to go back and think about it. But fundamental to paprika, it's using the principle of transitivity. It very much is relying on consistency, but that's a fundamental axiom of decision making. And so without consistency, you'll just go round and round in circles. Again, I'd be very happy to discuss that in much more detail, because that is an important question, absolutely.
Okay, and the last one that I see for now is, can 1,000 minds be used to single patient level decision sharing?
Single patient decision level sharing. I'm not sure what that means. The answer would have to be therefore yes, I think.
Okay.
Again, I'd love, maybe at the end, I'd love to talk with
to decide treatment together with the patient.
Oh, absolutely, yes, yes. So in all truthfulness, yes. And so we've got some examples as a tool for an individual patient making a very important individual patient decision. Not in this case, not in that example, but certainly in other examples. So a lot of people use this for personal decision making. I use this for choosing surfboards, not a health example, but yeah, and similarly a patient could use this for working on a decision with their clinical advisor. And I think that's a real important area that's underlooked, and certainly a lot of opportunities there. Yeah, absolutely. Can I move on, Petra?
Yes, you can.
Great. Now, I really want to stay afterwards, but I'm just conscious of some people who might have appointments to get to. Really quickly, and just in the last 5 or so minutes, 6 or 7 minutes, a great application that we were involved with was with the World Health Organization, trying to prioritize really nasty diseases that were becoming antibiotic resistant, to put them on a list to encourage researchers at universities and in drug companies to do research to try and find new treatments for these diseases. The 4 common elements that I've already talked to you about, this is what we're always focusing on. And in this case, the alternatives were 24, again, if you're not a medical person, you don't even know these things existed, but your great-grandparents probably died or were seriously ill because of some of these diseases. Antibiotics have kept them at bay since Fleming's discovery of penicillin, etc. But they're getting away because they're becoming antibiotic resistant. So the World Health Organization, in support of the entire world's population, wanted to rank order these 24 diseases from number 1 to the bottom, according to where research should go. So again, very quickly, went through a process to arrive at criteria, some weights, and of course involved decision makers that were experts in the field from all around the world, about 100 experts actually, and came up with some criteria. I'm not going to go through them, but there's an example of some of them. It's all in the journal article. Went through a process to arrive at weights, just like I have shown you several times before. There are the weights that they came up with that reflected the relative importance of the criteria. Described each of these diseases according to their performance on the criteria. There are the criteria down the bottom illustrated graphically. There's their scores that they're getting out of 100, and they simply rank ordered them. And then for communication purposes, they put them into little groups, sort of clustered them and combined some of them. Again, many of those diseases are actually very similar to each other, so therefore they could be condensed. And they publicized this list all around, through various sources, Nature, but in lots of news media as well. And this has been used to direct research into finding cures for these diseases as they get out of control again. So this was a great application. And what I think the WHO liked most about it was, this was a way to bring together experts from all around the world, from every continent, together in a collaborative fashion to reach a consensus and do it in a way that was valid and reliable, and that could be audited, and that they could stand behind, and that people could have faith in for such an important thing. I mean, literally, if these things get out of control, it's going to kill tens, maybe hundreds of millions of people a year. So that was why they were concerned. It was an eye-opener to me. I went to Geneva and worked with these people, and I hadn't heard of half of these, well, any of these things really. Why would you if you never suffered from them? Anyway, so that was a pretty interesting application. But again, I'm just trying to illustrate the breadth of applications, again, facing very important decisions. Final one, do this quickly. As COVID was starting to come into New Zealand, and as the country was going into lockdown, as other countries around the world were last year, the huge concern was there weren't enough ventilators in our hospitals to treat the expected hundreds and thousands of patients who had been incredibly sick from COVID. Just think of what's happening in India at the moment, in Brazil, other parts of the world a year later. So I've put the dates there, and so this was, this was a mad panic. So a group of experts came together 17th of March, and supported by Franz, me, Trudy Sullivan, Melissa Roy, Matthew Chiori, and a bunch of other people too, a whole group, ethical experts as well, and within about less than 10 days had come up with a set of criteria and weights to assist, to support these very tough decisions about who would get put on a ventilator and who would be offered alternative forms of treatment, which potentially, of course, could end in their death. I mean, you get to ICU, you're incredibly sick. So this was a very, life and death sort of situation. But there was something like, a dozen ventilators and ICU beds in the local hospital supporting a population of about 150,000 people. So they were expecting to be absolutely swamped. Now, as luck would have it, of course, it wasn't luck, it was good management. New Zealand didn't go down that route because of the quarantine, but they had to be prepared for it. And of course, other countries haven't been so fortunate. So again, 4 key elements. In this case, it's ranking patients for ICU, come up with some criteria and weights, and the decision makers were experts and ethicists in the field of ICU treatments. Just like I showed you for the other example of prioritizing patients, the experts got started with some patient vignettes. So here are 4 examples of patients who are very different, in age group and ethnicity and all their medical characteristics. And that was used to get the clinicians thinking about, well, why would we choose one patient over another, their prognosis. And those of you who don't know much about ICU, this was an eye-opener for me. As many as half of the patients who go to ICU aren't going to survive. You're incredibly sick, and it's a very serious place to be. So these decisions are very, very important. But based on the vignettes again, based on the expertise of the people, based on the literature, based on the knowledge that was coming out on a daily basis as COVID was happening all around the world, the clinicians arrived at a bunch of, I think there's about 10 there, clinical criteria for making that decision. And each criterion had a number of levels, just like I showed you in 1,000 Minds before. This is just a screenshot. This model's available inside the library of 1,000 Minds if you have an account. But of course, other things aside from the clinical considerations are obviously important. So in particular, trying to look after some disadvantaged groups in New Zealand, Maori and Pacific people who are very much at risk of COVID, and other potential groups as well, but also thinking about frontline health workers who could get sick in their job, or not even thinking about that necessarily, but just maintaining the capacity of the health system. We have to look after these people who are keeping the rest of us healthy. So that was a consideration as well. There's the sort of trade-off questions. I've already shown you how 1,000 Minds works. So they answered a whole series of these questions, the experts did. Now they did it by voting. So 1,000 Minds has a very nice voting mechanism. They did it online because we're all in lockdown. They answered questions like this, same sort of thing. And that produced the weights. Now we tried to incorporate the social equity considerations with the clinical things, but that just proved to be too difficult. It was too cognitively difficult. So the decision was reached certainly under the pressure of time to keep those things separate to begin with. And so it ended up criteria and weights, again, just the same old thing. We've seen this lots of times now in this talk. And alongside that prioritization tool, these other social considerations were to be considered on a case-by-case basis by an evaluation panel. Luckily, again, this wasn't required in New Zealand, but they were ready to go. And there's further work being done, improving the tool, especially with respect to these social and equity considerations. As you'd expect, I only briefly touched on it in my talk, but of course, lots of testing of validity and reliability for obvious reasons. These things have to work, and people have to have confidence. And I haven't got time to go through these, but of course, that's obviously very, very important in the health sector. A quick plug for other applications. Again, I've only talked on prioritization when there's a resource constraint. That's a major issue of the health system, but there's lots of other applications, certainly in the health sector, that MCDA, 1,000 Minds, is being used for. There's lots of information on our website. I'd love to talk to you, anyone who wants to. And only in the interest of time am I signing off from my webinar in terms of my presentation at 1 minute past the appointed time. So thank you very much. Please stay online and please keep talking, and let's have a conversation if you'd like to, but my presentation is complete. Thank you. And I think I can perhaps
Yeah, so I think I'm gonna allow everybody to talk, and then I
Yeah,
guess
that'd
if
be
you
great.
have something to say, you can just unmute yourself. Does that
Oh,
work?
that's why everyone was so quiet. You'd turn them off. Great. I'll keep my screen sharing up so that we can go back if anyone's got anything they'd like to see. So yeah, so any comments or questions or anything that we can talk about, that would be lovely. Let's have a conversation. We can, and I can go forever actually. So
Yeah,
I know
Paul,
some people.
perhaps I just published that. Can you hear me?
Hello.
Yeah, can you hear me?
Yes, I can. Thank you. Nice to hear from you.
Yeah, it's a pleasure, Paul, joining today. I'm joining from Toronto. I have just implemented a study as part of my PhD program at U of T. And so I find this webinar quite very interesting. But like you said, not surprising, within my study group, we've seen a lot of people pushing back at this methodology. Perhaps there's so much difficulty in understanding, the linear, regressional analysis on the back end that produces these weights as
Yeah.
well. And so, and also, within a community where you have very powerful people that prefer to make decisions themselves, and now they're losing that power. So there's
Yes.
always that kind of conflict. So this is just a general comment. Are there ways you think that people will benefit if perhaps the methodology is kind of toned down? Because when I read your paper, it's fine, I did understand it, but many people will find it difficult to understand what the computations happen at the back end.
Yeah, that's a great question. I mean, and the computations are phenomenally complicated. Like I'm just glad Franz and I wrote the methodology down when we did, because the passage of time. You're right, but I really appreciate you reinforcing that notion of pushback. There is a lot of pushback against this, and sometimes I think it's a power thing, and people feeling excluded, and particularly older people feeling that somehow the computer is taking over the human side of the decision. So I think certainly getting into explaining how the methodology works, the algorithm can be useful, but in fact, I don't think a lot of times that people are that interested. I use the analogy, I drive a car every day and I have a rough idea how an engine works, but I don't really want to know the details. I know that I put fuel in it and it drives me forward. And I think we can get a similar level of understanding of, like how the answers to those trade-off questions that I showed you in 1,000 Minds, how that generates the weights. And we could go into that later on. And our website has an attempt to try and explain that in non-technical terms. But I think the major pushback, and that's certainly discussed in that Kahneman book that I was talking about, and I'll just go back to that because I really do want to encourage people to look at that. Oh, this wasn't a very efficient way of doing it, I'm sorry. Certainly, chapter 21, he talks about people's reaction against that is, and I think it's because they feel that they're losing their agency as human beings, and they're being sort of disenfranchised from a decision. So I think, therefore, the solution to make people feel comfortable with it is to just get them more back into the system, or more back into the process, whereby they can be included more fully. I'm obviously getting tired here and bouncing around crazy. I'm just trying to find that picture there. There we go, there. So I think, this diagram, I think, is very illustrative of that. The model building side of things, that's where we use the tools that I've been demonstrating. But all around it it's all human driven. Like this is all about people talking together, facilitation, sharing ideas. So I like to think about it, I try to allay people's fears by saying these tools that we're going to use to build a model, like in 1,000 Minds, but other tools as well, are really just, a system that we're going to use to try and bring us all together in a structured, transparent, explicit, inclusive, participatory fashion. It's not like they're losing their ability to make decisions. And in my experience, doing this for 20 years or so, once people realize that, they kind of relax. It's like, I don't know, you're probably not old enough, but the first time you use Excel, you think, oh, why aren't I doing calculations just on a pen and paper? The computer's taking over, and you're a little bit apprehensive, but then you realize it's a tool of incredible power. So I think that's what MCDM is about too, but the socialization and the reassurance of people and bringing them along is very much an important part of the process. So oftentimes when we work with people, It's finding a champion within inside the group who the people respect, and that they share a common language. So oftentimes, it's a partnership. So we at 1,000 Minds, we'll often partner with people within the particular application and work with them. We'll support, if you like, the model building in this picture here, but they'll lead and facilitate all the other stages. And again, I love coming back to this diagram because, the model often sends us back to the very human-centered thing where we think much more deeply with greater insight about what is the actual problem that we're trying to solve here. Have we thought that through, rather than sort of leaping straight into the problem, as so often happens when we don't have tools available. But Taramobo, can I ask, have you looked at that chapter that I'm referring to in Kahneman? Because it's a very nice discussion of that. I can send you a photocopy of that chapter if you'd like. I think you'll find great reassurance from that, probably.
Oh yeah, I mean, this is my first time, joining a live situation like this. Obviously, like I screenshotted, by the way, just letting you know that particular book, and I'm very much interested in going to look at it. But I mean, if others have something to say, that was just like an opening statement. I do have some perhaps specific questions about the system because I used it. I think this might create an opportunity for me to ask this one, but let me give other people an opportunity.
Yeah, it's great. Well, I will send you the chapters just so that you can perhaps read them over the weekend, because it totally relates to what you're talking about. Does anyone else have things that we can talk about, or that I can go over or explain perhaps I didn't provide enough information about? Is everyone muted, Petra, because of your control, or are they self-muting?
They self-muting. If you want to talk, if you want to say something, you can unmute yourself.
Yeah. But maybe
a self-muting actually a word.
Yeah. Not from you, Tony. How are you?
Thank you.
Well, maybe we're out of we're all tired, and we've got going either. For those of us in New Zealand, go and have some breakfast. For those of us in other parts of the world, go and have some lunch, or maybe have some dinner.
Yeah, Paul. But if you allow me, just one more question for today.
Yeah, please.
Perhaps the others will go through.
Go for it.
Yeah. So when you look at the platform, I was just trying to follow you because I do have a study that was just concluded. We had a challenge in estimating the paired rank agreement of alternatives, and as well as computing the correlations between the pairs of participants. Mm-hmm. And so is this is this a limitation in terms of the scope of the data, or is this something that is supposed to be it's supposed to be an output? I mean, I thought perhaps an email might make it a little complicated, but it's from our own experience that data was not able to be produced, so we had to now export the data. And now
which data do you mean, like a correlation coefficient?
Yeah, so you know how you have trade-offs, right? And you have multiple people giving the trade-offs. And so we wanted to see how they were agreeing, the paired agreement and the correlation between the pairs of participants. That data didn't output in my study.
But you didn't run it as a survey, though? You ran people working as a group answering each trade-off question, or did they individually answer the trade-offs on their own through a survey? So again, I didn't demonstrate it, but a big part of 1,000 Minds is we can turn anything into a survey, right? And so they go out and answer it individually. Their results come back individually. There's quite a lot of reporting about the correlations between both the weights, but also the rankings that would be produced of, say, the patients. I think we've also got a page that Franz could jump in. He's oftentimes more familiar. There's that looks at the degree to which people answered the same sort of questions the same way, but that's through the surveying feature. So maybe you didn't use that. I'm just not sure. Did you use that?
Yeah. My study was the survey feature. Yep. But unfortunately, we couldn't. When you go on the sidebar, it gives you an opportunity to show the median in table, show paired rank agreement alternatives, show correlation between pairs of participants. Unfortunately, when we tick all of that as the option, when you go to the results, you still do not see it. I mean, this is not something you're gonna take care of here. I mean, I'm just
well. So let's take this. Let's have another conversation, another Zoom, and we'll try and help you with that if that's the case. If there's something that wasn't working, we'd love to support that. Absolutely.
Okay.
So do you want to anyway? Let's have an email exchange and maybe talk later today or next week if you've got time.
Oh yeah, I mean, frankly, yeah, I mean, our next meeting, I'll probably let you know, because I'm actually, preparing to kind of defend this methodology. So I find, some of these insights in the webinar. So yeah, I mean, it depends on your availability. I'm very open.
Very much. Look, always want to help. So don't hesitate. Please get in touch and can help with other things as well. Would love to.
Okay, we have another question. Do you guys still have more to say, or good? We're good.
I think we'll take it offline.
Okay.
Yeah,
so we have another question. How would you compare 1,000 minds to the grade evidence to decision process?
The great evidence to decision process.
Yeah,
I don't know what it
great.
is.
It's you know that one, or?
I think, was that one of the ones on the
it looks like it's an acronym, so I assume it's a methodology.
I'm revealing my ignorance, perhaps. It's not one of these. Evidential reasoning approach. I thought it might be that. I don't know is the answer. So please send me some further information so I can educate myself about that. I'd like to learn more. Or send a link. That'd be great. And I'll certainly answer your question once I know what the other things that I'm comparing it with. Anything else?
There's nothing in the Q&A. There's nothing in the chat. I guess nobody has anything else to say or ask, or.
Oh, right now I can see it. Okay, that's great. Oh well, I mean, maybe we're done here, but please, anyone, get in touch. We'd love to talk more. Love to give you a proper demonstration if you haven't seen 1,000 minds before, and you'd like to have a proper demo, go through an example related to your own interests, and certainly show you the surveying tools. I didn't even get into that, but the surveying tools are incredibly powerful. We'd love to. So send an email to me or Petra or Franz, anyone else.
Do you want me to put your email in the chat or the team email, or?
Yeah, sure, that's great. Or just
which
find
one?
us on both. I don't care.
Both, okay.
I'm very easy to find, of course. Paul Hansen, Google, you find me, or 1,000 minds. Just an email to 1,000 minds will come to us all, and we'd very much love to help. I think, yeah.
Okay, so I put both of the emails where if anyone has any questions, you can reach Paul at either of those. He checks both of them every day.
I just found the chat feature, so there you go. There's a nice learning for me. Okay, well, thank you again, everyone, for making time to come and listen to this talk and to participate, especially. Thank you very much, Petra, for organising it and for coordinating everything, doing a great job there as always. And I'll say goodbye, and please be in touch.